So inshallah, we'll start our session. So first, I'd like to introduce our chairperson, Dr. Tahira Nishtar. She's the chairperson of the radiology department, Lady Reading Hospital, and well-known radiology personality of the Peshawar. And then we have got our other speakers, and as we'll present their talk, I'll just go through them. Our first speaker is Dr. Damien Tolan. He's a very nice person and a mentor. And he's a consultant radiologist at Leeds Teaching Hospital with a special interest in rectal and luminal imaging. And he's also BESGAR, which is the British Society of Gastroenterology, Abdominal Radiology president for 22-24 session as well. So I will, and he has also joined online as well. And we'll also take the questions at the end of the whole session as well. So please keep your questions. So I will start his pre-recorded talk.
For the Shaukat Khanum Cancer Symposium. And I'm very grateful that my friend Ahmed Iftikhar invited me to give the talk. I'm just very sorry that I can't be with you in person because I've been giving talks in the UK this week. So my job is to talk to you about controversies in TNM staging for radiological. Countries in the North of England with about 5 million patients. We've been working with 13 different entities in our area to try and improve the outcomes for our patients. We've been working with these entities to look at what is in an MRI report. And we realized that when we did our first assessment, that only about 22% of entities use pro forma reports for their MRI scans. And that's despite them realizing and their clinicians actually miss out. So what did we do? Well, we decided that there was a change required, and we developed a Yorkshire-wide rectal cancer pro forma report. We developed teaching courses for our radiologists on pro forma reporting involving my friend Daniel Lambrex, and we really decided that we were trying to make a change. So what have we done with that improvement? Well, between 2016 the number of radiologists using template reports increased from 22% to nearly 47%. That's a very substantial increase. And also the amount of completeness of reports, all of the key areas of the report, has increased, particularly in the number of people that take up the template reports. So overall, it's not just about how radiologists. It's really important to realize radiologists use this for us to And we have to ask, can we mix? Is this an easy thing for us to do if we were to try? The problem we have are scans. So we have a baseline scan, where we can see the area circled that there is a malignant pelvic sidewall node. This is an obturator. Hardly captured in the scan at baseline, but you can see that as a result of that, the oncologist will be able to treat that patient with this lymph node, so the tumor has progressed during the treatment. Now they've got a more advanced stage. So what we've done is to try and treat the radiography. We looked at how the radiography actually looked at scans and how confident they were examining scans to see whether they were of good enough quality. And you will see that there's quite a large amount of difference between quality assessed by gold standard expert radiologists. You can see this little dot here is the expert radiologist assessment, and the assessment that the radiographers give these images. You can see that in some cases that is a very, very big divergence from what the gold standard expert says. In this case, the expert has said that the scan is not covering the tumor at all, but the radiographers felt that the scan was actually covered. And again, you can see that there's other cases here. The radiologist judges the standard of the scan lower than the radiographer. This is the problem. This tells us that radiographers don't know what to do. But we also do need to work on radiologists. And we need to expand in which of the radiologists find it. Difficult areas radiology find it, trying to advance disease. I think some radiologists find it difficult to appreciate the adverse features that maybe require a more radical approach, either with radiotherapy, chemotherapy, or surgery. And also radiologists find it difficult to assess disease response. Surgeons, oncologists, pathologists, and radiologists. Next, to try and determine what these key areas of difficulty were, how we can solve them. That was involved. What were the areas? Well, what happened was we surveyed a large number of radiologists from around the world and asked them to look at images, to try and determine areas that the radiologists struggled with. It became very clear that radiologists struggle to understand the difference between circumferential resection margin and what the mesorectal pressure is and the peritoneal. Because obviously, when the surgeon makes cuts, circumferential reflections, these are not. So there is some education required to determine where the peritoneal reflections are and the significance of the difference between the peritoneal reflection and the mesorectal fracture in the treatment. Another aspect that needed clarification was how we should actually categorize the involvement of the mesorectal fracture. There was a lot of confusion about whether this term threatened should still be used, where if the tumor or adverse feature comes within 1 to 2 millimeters, that this should be called threatened. But the multidisciplinary group felt that this was just confusing, and we need to actually simplify to just involvement of the mesorectal fracture or not involvement. And involvement now defined as where the margin is within 1 millimeter either of the primary tumor, site of extramural venous invasion, or tumor deposits or irregular pathological deposits. The mesorectal fracture should not be considered involved if the tumor is close to or lymph nodes with smooth margins that are close to the mesorectal fracture. These have been shown in studies actually have a very poor risk for involvement of the circumferential protection margin and the risk of later tumor relapse. So this should no longer be considered as being an involved margin between capsulated lymph nodes with the lymph. Another thing that we have found is what to call P4B. In particular, what to do with the obviously the tumor exposed beyond the expected fat is a problem because it means that surgery is going to be more difficult and this complicates also the radiotherapy. So we've defined that P4B should also now include any involvement of the fat or muscle beyond the. Another area of weakness is our evaluation of pelvic lymph node stage. And that there's a widespread deficiency of knowledge in which lymph nodes live in which compartments of the abdomen and the pelvis. And I would really urge any radiologist in the audience to read this paper because it also includes a fantastic series of images that actually show you where all of the different lymph node stations are. You can use this in your interpretation. However, what's really important is to appreciate that pelvic side lymph nodes do not look or behave the same lymph nodes in the knee. And so in pelvic side lymph nodes, the primary way to find whether a lymph node is involved by tumor or not is purely by size lymph nodes. If a lymph node is 7 millimeters or greater, it should be considered an involved lymph node. So very important new knowledge there to take into account. Now, in addition to actually knowing these observations, we need to look at them. So I think that radiologists often miss these lymph nodes. We're seeing them more and more frequently now. And we can see here that there's a misobturated lymph node not appreciated by the radiologist. However, when we do the research scan as part of the trial, we detect this lymph node and it's therefore included in the radiology. Which is a chance of patient will relapse in tumor recurrence at some time in the future. So how should we improve our practice? Well, we can improve our practice by using reporting templates. And you can see that in our Yorkshire reporting template, that there's a lot of standardized detail in the report describing the position, the length, the size, the shape of the primary tumour, and a description of the lymph nodes and where these lymph nodes are. Again, so the surgeon oncologist can clearly define where these lymph nodes are. Also, a description of the presence of extramural venous invasion, description of the mesorectal fracture status, whether this is involved or not, and then a broader description of the different issues around the tumour, whether there are any specific features that need additional description, for example, involvement of particles. We found that using this reporting style that both the clinicians and other radiologists find it a very, very satisfactory way to look at scans and also to review each other's. Because we know that there's so much more similarity between our reporting styles, so that if we review cases in the MPT, it's very, very simple and straightforward. We need to be more and more looking for additional levers to keep looking at these structural increasing in the observation of lateral muscular drainage with the middle ventral artery. This is really quite closely associated with pelvic sidewall lymph node involvement. And you can see that if you have unilateral or bilateral middle rectal nodes, this dramatically increases the chance that you will go on to develop lateral pelvic sidewall lymph nodes. So again, look very carefully for this, your patient, because you see those vessels, look even more carefully at the sidewall for those involved lymph nodes, and again to detect those and point them out in the report. So what are the challenges? Well, I think as time goes on, we will hopefully get better and better at detecting the abnormal tumour features that can potentially pose a risk of tumour recurrence after treatment, after standard treatment. We can see in this case, a patient who has a right anterolateral middle rectal artery. You can see that the artery is penetrating through the mesorectal fascia about 10 o'clock. And there was no tumour there at that point. But then around 12 months later, developed a rising CPA. And we can see that now there is a new tumour nodule, which is actively outed and confirmed its surgery with a recurrent tumour. And that was successfully detected with negative margin, and the patient remains disease-free. So, how can we challenge ourselves? Well, I think we have to set standards for how we should be performing. And certainly in Yorkshire, our aspiration is that in the future, everybody will use reporting templates, try and make sure that all of the descriptors are used in routine practice. So, again, something that you consider whether this is something that could improve performance in all of your hospitals. Because the challenge for us is that we know now we have powerful techniques everywhere. But the problem is that we have great variance in how we report our scans, we have variance in how images are required. And the question is that we're all quite smart people, but why is there so much variance in 2023 when we know really quite well what lots of the best ways to do things are? So I think that's a challenge that I will throw back to you in the room. It's a real pleasure to talk to you all in this talk, and I hope that I'll be able to join you for the question and answer session later. Thank you. Hello everyone, my name is Damien Tolan. I'm a gastrointestinal radiologist from Leeds, in the north of England, and it's a great pleasure to
If we're talking about I'm trying to keep this solved really simple. It's a very complex topic. Since that I studied this thing, a lot of new research so I just wanted to do this and create you. And we will discuss all of these things, why are these cases our so a couple of definitions are important to you actually. Tumor progression, which is where you get a tumor enlargement of tumor enhancement, where subsequently you find out that it wasn't actually tumor. This is the difference from radio necrosis, and therefore needs to be there.
Necrosis is something that we are all familiar with. Radionecrosis is brain tissue being affected beyond where you wanted it to stop. So ongoing necrosis induced by the endarteritis that the radiation has induced. And lastly, pseudo response, which is a little bit difficult to judge, but it is where you see a change due to permeability of the tumor rather than actual tumor apoptosis. This is becoming much more of a problem when we're using VEGF and other agents which change vascular permeability. And I think this is going to become a problem as we go forward. It's not currently something on our horizon, much less than the other two. So let's just, the thing to remember is that it's very difficult if you use standard imaging techniques to differentiate between these things. I'll show you cases and you'll see how similar these things can look and how deceptive these things can look on the standard MR. And it really takes metabolic imaging or some additional MR techniques to try and sort these out. What is even more confusing is that very often more than one of these processes occur either in the same tumor at one point in time or in the tumor at different points in time. So you can have one part of the tumor that is showing tumor necrosis or radiation necrosis and another part of the tumor that's actually showing active proliferation. And therefore trying to make sense of the imaging can be challenging. And just to give you a list, and the reason I've put advanced in inverted commas is because a lot of this is now standard of care when it comes to MR imaging. Certainly susceptibility weighted imaging and diffusion weighted imaging are part of every brain scan now. Perfusion is still used a little bit selectively. I know there are centers that will do a brain perfusion for every follow-up MR on tumors, but that adds cost and that adds time, and therefore in our environment it's still a luxury that I don't have. Spectroscopy is a bit plus minus. People who know me know that I am not a great proponent of spectroscopy, but it has its uses, it has its some advantages. So let's start with the cases. This is a patient who's had radiotherapy, has headache, has aphasia, has right-sided weakness, and this is the scan. So what does radionecrosis look like? Well, typically radionecrosis would be an enhancing area adjacent to the tumor or within the tumor field. It may have irregular margins. It almost never has diffusion restriction, and it almost never has hemorrhage. So if you look at this one, it's fairly atypical, right? Because this thing working? Okay. This one? Okay, sorry. So a little bit atypical, diffusion restricted, hemorrhage. So why am I confident that this is radionecrosis? This is absolutely radionecrosis. This is May 2013. This patient did not get radiotherapy for a GBM. This looks like a GBM, right? Did not get radiotherapy for a GBM. This patient has meningomatosis. Had a sphenoid wing lesion that had doubled in size over 3 months and was actually being treated to control this. This is March 2013. This is 2 months later. She's not going to develop a new large GBM in 2 months, right? This is radionecrosis. So I know this is radionecrosis. All I'm trying to tell you is what sometimes you know this is radionecrosis, but you still find it difficult because a lot of the times these lesions don't read textbooks and don't follow rules. Just for the residents in the room, the reason this one shows is diffusion restriction is because it has hemorrhage. And you know, when you have hemorrhage, the diffusion restriction paradigms go out of the window. So that's the first case. This is more of the regular thing that you see. This is a 64-year-old male, GBM, IDH wild type. We don't know the methylation status on this guy. Presented with recurrence, and you can see that this is a large heterogeneous lesion. But when you compared it with the prior exam, which was 3 months prior to this, there were two areas which were new. One is the solid nodule at the lower end of the resection margin, and the other one is this very heterogeneous looking lesion up in the centrum semiovale in the periventricular region. Now, if I had to put money on one being radionecrosis and the other being tumor recurrence, how many people would say that this was radionecrosis? How many? Just show of hands. I agree. That's what I thought. I thought this was tumor necrosis. This was until we did the spectrum. And that's tumor necrosis. That's new tumor. So two things. A, two different phenomena in the same patient. What you thought was one thing is not. So keep an open mind, use your techniques, apply them, and then try and make a decision as to what you're dealing with. Spectrum is not always that helpful. Like this case will show. 61-year-old male. The astute ones among you would notice that there is a speck of calcification, and you would also notice that there is no discordance between the flare and the T2. This was resected, and on resection turned out to be a high-grade oligodendroglioma. Pretty good resection, you would say, no? This is some T1 hyperintensity secondary to the blood. No real enhancement, a little bit of residual edema. 3 months later, after completing radiotherapy, the cavity is gone, but he's now developed an enhancing nodule. What do you think that enhancing nodule is? We couldn't figure it out. We thought it was too small to put it through our perfusion paradigm. So we tried to do a spectrum on it. Spectrum looks pretty good in the sense that you think that this is a high choline and a depressed NAA. This was done on a 1.5 Tesla, so the inverted doublet at 1.2 lipid lactate, until you actually look at the side. So the ratios would still will probably indicate that this is high choline, but then if you look at the absolute numbers, you realize that there is just no signal there. And all the computer is doing is stretching that graph out so that you can see the peaks. When you compare it with the other spectrum from the normal side done at the same time, you realize that this really is a non-contributory MRS. So you don't really know. We followed this up, and this turned out to be nothing. This nodule just remained there, and then 3 years later was the last time we had a follow-up on this guy, and he didn't have any recurrence. This is a 66-year-old lady presented with a single solid enhancing lesion, surrounding edema, mass effect, was resected in July 2017, turned out to be metastatic adenocarcinoma, was under surveillance. We didn't find the primary, had radiotherapy. 18 months later, started to develop these little nodules, which one nodule is diffusion restricted, the other one is not. Don't know what they are. We thought we would just follow them up. We did. In March 2019, this thing had grown. No diffusion restriction, but significant increase in size. There is peripheral enhancement. Did a perfusion study. Remember, perfusion study, what you're looking at are the CBV maps. This is a CBV map, and this is profoundly hypovascular. The patient also had a PET. PET for brain, FDG PET for brain is useless. The only indication it has is this one. Radionecrosis works really, really well. Otherwise, you really need to be looking at choline PET. to look for tumors. This we read as radionecrosis, and it over time this has stabilized. So this was just 3 days ago. Patient has come in, has some scarring, but has actually no further tumor there. This is a 46-year-old female post-resection. Turned out to be a IDH wild type high-grade lesion, GBM, radiotherapy. Soon after finishing radiotherapy, developed this enhancement next to the resection margin. CBV maps demonstrate that this is profoundly hypervascular. Remember, on this scale, redder, brighter the red, the more blood flow there is, the more blood volume there is. This is hypervascular. She was offered further resection. She refused, and this is her in November 2019. I believe she has since passed away. It's an interesting one, 32-year-old male patient. Initially, with a lot of inflammatory features, we thought this was a brain abscess. The surgeon went in, found that this was actually a tumor. On histopathology was a weird dysembryogenic embroblastic tumor. This is the immediate post-resection exam. I can see whether they have taken the tumor out. You can see some enhancement on the periphery. Patient was put on a cocktail of fancy drugs, and a month later came in with left hemiparesis and depressed consciousness. This was the MR. Lots of edema, lots of enhancement. And the question was, what are we dealing with? We did a CBV map, and this actually has absolutely normal vascularity. This is not hypervascular. This is not hypovascular. So we stuck our necks out and called this pseudoprogression secondary to the VEGF. They continued the therapy. They didn't change anything. And this is May 2023. It has all settled down, gone away. So this was actually pseudoprogression. Bit of a learning case. This was a GBM, was resected. This is end of radiation scan. You can see there is some enhancement around there, but there really is nothing where this lesion is. 3 months later, increasing headache. We did the scan, found that. Question again, is this radionecrosis? Is this tumor recurrence? We did a spectrum and a blood volume map. The spectrum indicated that this was tumor. The volume map indicated that this wasn't. So what do you do now? So we ran kind of a QA, thought, let's see. And when we run the QA, I don't know whether this projects at all. You can see that the bolus profile on this one is really, really bad. There really is no depth. So what you're looking at is not a representative image. We called this patient back next day, repeated it, got a much better profile, and now we have concordance. This is hypervascular. The only reason, so when you're doing perfusions, make sure that your technique is right, that your techs know what they're doing, and that somebody, before they let the patient go, has a look at the curves to make sure that there isn't movement, and you had a good profile. I'm coming to the end. So this is the last patient. I just put that in for sake of completion. I don't know whether this is true pseudo response or not. This was a recurrent GBM. 1 month on, the hemiparesis didn't get better, but the headache did. We called this very good response. That's early on, except the tumor proved us wrong and came back with a vengeance. So whether this is actually pseudo response or us undercalling it, I'm not quite sure. So to conclude, pure anatomy using size-based criteria such as McDonald's or Rano's is no longer valid when you look at tumors. Especially true if your oncologists are using immune modulators and anti-angiogenic agents. And currently, in everyday practice, DWI, PWI, and MRS with FDG, PET in selected cases is where you need to be. Thank you.
Thank you very much, Dr. Zafar Sujat, for informative talk. And now the next speaker is Dr. Ram Chital. He's a consultant radiologist at Mid Yorkshire Hospital, and he will talk about learning from discrepancy. And Dr. Ram Chital, he's in addition to being a consultant at Mid York Hospital, he's also a medical member of the panel of the REAL, which is the learning from discrepancy panel of the RCR. So we'll go through his presentation and then we'll save the questions for the end. Thank you. No, we'll go for pre-recorded. Yeah,
Hello, everybody. Thank you for your kind invitation to give this talk on learning from discrepancy. 22nd Shaukat Khanum Cancer Symposium, Peshawar. My name is Dr. Ram Chital. I'm one of the founding members of the REAL project at the Royal College of Radiologists, which is a national platform to learn, share experiences. I would like to dedicate this talk to one of my favorite teachers, Dr. Sami Khan, who has taught and inspired thousands of radiologists around the world with his selfless teaching. The objectives of my today's talk are a brief introduction to radiology errors and the value of shared learning from errors without blame and shame. The thought of appreciation was, and I will briefly give an overview of the REAL project. Errors in medicine are common, as you can see from the data taken from this BMJ publication. The estimation is that the medical error is the third commonest cause of death. So it is no different in radiology. The published data suggests that error rate in radiology varies from 3 to 5%. More focused studies suggest that error rate to 15%. Let's go to this case. This is a young patient with previous complete resection of thymoma, and this patient had a scan just done 2 years post-operatively and look for any recurrence. As you can see, the report currently identified the big mass lesion, the mediastinum, and called it recurrence of thymoma. However, 2 weeks down the line, the patient represented to the emergency department with symptoms of paraplegia. And when we looked at the scan, again, there was this large paraspecific mass at the very edge of the scan with spinal canal encroachment and cardiac compression. So, what this case demonstrates is that mistakes have got consequences. In this case, the satisfaction of search was the reason for this mistake. What I mean by that is, if there is a large mass and you identify something, our brains and eyes stop looking for more. Once we find an answer, one can easily switch on. However, what we have to understand that mistakes doesn't equate to negligence. When things go wrong, there is this concept called fallacy of single cause. This blaming game dates back to Stone Age practice of hunting for scapegoats. Actually, in complex situations, there is never a single cause, but we are required to trace crimes or disasters back to individuals and stamp them responsible. This type of approach of blaming is flawed and can be dangerous. I wanted just to cover this kind of concept called as drawing the bullseye around the arrow. Say when you come across a mistake, it is easy to draw circles around it and build a story around it. How to address this? You have to ask the right questions. You have to look for any system factors involved for a mistake to happen. And we have to be aware of hindsight and story bias. We can learn from such events more if we take the right approach. We have to accept that mistake is an opportunity to learn. Discussing them and sharing them anonymously will help everyone to learn from errors. If individuals are not informed of their errors, they will believe that they are working safely and thereby continue to make same errors again and again until they get into serious trouble. What we need to appreciate is most medical discoveries or other discoveries are accidental to something else. An error-free world would have no penicillin, no chemotherapy, almost no drugs, and almost probably no humans. So it is very important we should reflect and learn from mistakes. Coming to the next part of my presentation, how to learn without blame and shame. As you can see, there are several challenges. Mistakes happen, how to discuss them. For example, the emotional impact it can cause, the risk to your reputation, feeling of guilt, the risk of fear of losing our jobs. It is challenging within the UK. We are fortunate to have these kind of radios, events and learning meetings, which happen on a monthly basis in most departments throughout the country. What exactly happens in these meetings is, in my reporting time, okay, case somebody has missed something, I would like to get designated relevant chairperson in our department, explaining this is a case where this so happened, there's some learning points. So all colleagues who come across any errors in the department, they write to the chair of this meeting, who collects all these cases, anonymizes completely, and then discusses in our monthly meetings in a very respectful and in a blame-free environment. So when we discuss this in the meeting, nobody knows who reported and everything is anonymous. There are no identifiers. And also, in these meetings, the advantage is all the subspecialty experts are sitting in this meeting. So if there is a mistake in an MSK system, there are several senior MSK colleagues who give top tips how to, they share their own experiences, how to avoid such mistakes in the future. And these meetings increasingly, we just not discuss only mistakes, but also share colleagues who are interested.
last electrical was almost. Then we look back. And yes, there was a nodule that is in the so when we discuss the case, these images, and then we go to the points. For example, in this case, we also put the available images to understand. Right? So this is some of the point. And this is the paper which centrally we had a common area where one can easily compute the present model is the first place of awareness of the properties within complex some revenues. We also count the colleagues rather than stand by. We will go. This was a PPA and the of complex situation right now to be treated about it. The reason being, we answer the of another I look at the this is great, but I can PPA and I will say this subject is interesting celebration of the money. Subtle capacity, you're right. Or is that but that evaluation
वो नहीं आ रही है वो नहीं आ रही है
so there are multiple benefits that are
नहीं कर रहा
overall
लैपटॉप पे रन करें एट द सेम टाइम सबको पता लगे क्या आपको फ्रेंड को देते हैं ना इसमें है अगला क्लास किस पर है
Yes, few minutes, I will even overview the main project. Now you can have a year as I mentioned, for every hospital have these meetings when you can for the local diseases.
So with that idea, we got about this. Myself, points. Now, how does it work? So this is an online recording form. So somebody is the case in Birmingham. I'm not into the panel members. We further monitor this. A collection of cases are published as quarterly. Here, the distribution word changes. We have more opportunity just about cases if the previous knowledge, for example, this is the previous radar I found here is technology. Technology, technology, and practice of the we should take this to cases where the system cannot exist. So we have presented it in other design currency here. The different cases are said, and interestingly, most of the cases have been a positive response. So the project so far in summary has a positive impact locally, nationally, and now internationally. Inspired by this work from the real project, certain institutions outside the UK are reporting that they are setting up similar meetings, aiming to learn from errors in psychologically safe environment without blame or shame. Here, we have also learned from authorities abroad who have implemented international administrator, which is based on how errors are managed in different countries, what kind of barriers they face. Hopefully, this will be a long-term collaboration. So this has been the journey so far. What started as a local discrepancy meetings, which became a national project as a big project, implemented as major events and cooperation with all the other process. So this is the summary of the journey of the big project so far. And we don't know what lies ahead. I believe that the other project is just it's of a long and exciting journey. Hopefully, in the future, open up many new possibilities which can potentially have a positive impact on the process of shared learning across the countries, which innovative ideas grow things for us. My final take-home point is that we have to accept that we always have to feedback full of ideas.
sharing certain things, share of learning. To make that even stabilize, you can see how the opportunity is. Every possible. Hello, everybody. Thank you for your presentation. I know that the people who are studying online, there are different teams. This includes, I apologize for it. And we are talking about to solve it. In the meantime, we have a live session and the recording of all the sessions and the replay calling on as well. This is available online to be watched later. And I was apologize and thank you for the thank you. Now over then.
About any activity related anything finding and challenges in early diagnosis. About the anatomy of the answer, the role of the and the challenges ARs resolve the early diagnosis, the P1 and the P2 stage, the early diagnosis of the embryo and the peri-embryo. It's short of time, so only touching the part. So, what is ampulla? Ampulla is the common channel of MPD and CPD. So basically, the CPD and the MPD will unite, they form the ampulla. So the common channel is called ampulla. Any area around the ampulla within 2 centimeters of the dia is the peri-embryo region. And the peri-embryo region covers the papilla, the nearby frontal mucosa, which is the bone, the pancreatic duct, the CBD, as well as the pancreatic parenchyma. So any tumor or malignancy from origin of these nearby structures around the ampulla compromises the peri-ampullary malignancy. So this was a beautiful image showing the variation in the ampulla, which should be kept in mind. It can be a dilated or normal structure. Sometimes we don't see the normal union, and both the ducts, they open directly in the papilla. So what's the role of imaging? We have to have the CT and the MRI both, or either one, in a triphasic technique, and an MRCP. This is the normal anatomy of the biliary and the pancreatic duct, showing the confluence and the beautifully seen ampulla. And this is a coronal reformatted post-contrast CT, and the arrow is pointing at a huge large mass, which is a T4 mass, which has involved the pancreas and the pancreaticoduodenal groove. But here we see that it's caused the biliary dilatation and the MPDSL spared. A long list of peri-ampullary pathologies. We'll just focus on the 4 main malignancies here, starting with the ampullary CA. It's a rare malignancy, and often obstructive symptoms, they arise early in the diagnosis, and a curative surgery is possible. On imaging, what we see a discrete nodular or a polypoidal-like filling defect at the distal margin of the confluence of the MPD and CBD, and on the difference of the ampullary CA from the other peri-ampullary CA is the contrast enhancement pattern, where the ampullary CA shows enhancement on the arterial phase as well. Its borders are lobulated or infiltrative, and diffusion has a role. And on imaging, we will see a double dot sign on MRCP or the corneal reformatted CT images as well. So here we see a heterogeneously enhancing mass involving the ampulla as well as the periampullary region. You can appreciate the hypervascularity in the lesion even on the venous face. And on the MRCP, we see a small rounded focus at the ampulla, bulging the papilla, and it has caused upstream ductal dilatation. This is the lesion. Again, a double dot sign. And when we trace the axials, a small lesion was seen at the ampulla, very small, 3 millimeter. Another case from our center, double dot sign. And when we trace the axials, the axial T2 showed a slightly hyperintense 2 millimeter nodule involving the ampulla and the papilla, and this was a T1 stage lesion. Okay, the other malignancy seen here is the distal CBD cholangiocarcinoma. We all know cholangiocarcinomas are hypovascular lesions which show progressive enhancement. So the role of delayed phase comes here. It has two types, the intrahepatic and the extrahepatic. And here we're talking about the extrahepatic form, which is either infiltrative or a polypoidal. And the imaging sign, the most important imaging sign here is the wall thickening. The wall thickening in addition to the luminal obliteration. That is the additional feature of distal CBD cholangiocarcinoma, and it has a slow enhancement. Here we see a polypoidal projection in the distal CBD. The lowermost CBD near the ampulla is normally visualized. So this was a case of distal CBD cholangiocarcinoma. Another case where the ampulla is involved, distal CBD mass showing enhancement on delayed phase. Another patient, distal CBD mass, you can see filling defect in infiltrative mass in the distal CBD. The other malignancy common here is a duodenal adenocarcinoma. Its literature says it's a rare tumor, but it's not that rare in our population. Especially in our area, we get referrals from Afghanistan, and duodenal CAs in the periampullary location, endoscopically, histopathologically proven, are not that rare. So the difference of duodenal adenocarcinoma from the other periampullary carcinomas is, number one, its hypovascularity. Number two, it's slow growth, and usually the patient when presents either when the ampulla is involved, then there is biliary obstruction, or when there is gastric outlet obstruction, then the patient presents. So we have a polypoid fungating type mass. Here we see a hypoenhancing lesion, somewhat eccentric in the duodenal wall involving the ampulla with resultant upstream dilatation. I would like to emphasize here the role of windowing and the post-processing techniques while you're sitting on the reporting stations. When you change the window, you can appreciate how beautifully you can see the tumor, its extent in the duodenal wall, and how it has infiltrated the ampulla and the lower CBD opening as well. Again, the axial section, we can appreciate a hypo-enhancing lesion in the medial duodenal wall at the level of the ampulla. And again, by changing the window settings, it is more beautifully appreciated. So play around with your workstations, and this will benefit you in your diagnosis and patient benefit, obviously. Okay, the other CA common here is the pancreatic adenocarcinoma. When it involves the ampulla, it's mostly at the head region. Pancreatic CA of the head not necessarily involves the MPD. So if you don't see a double duct sign, it's not necessary that this patient does not have a pancreatic CA. You have to have the look at the MR, especially the T2 weighted images, where the lesion is hypointense as compared to the surrounding pancreatic parenchyma. Again, a lesion here in the periampullary region, a large mass, a T3 mass involving the pancreas, the duodenum, and the ampulla. And on T2, slightly hyperintense as compared surrounding parenchyma, but you can appreciate its surface rounded contour deformity. It's different from the regional rest of the pancreatic parenchyma. It has not caused pancreatic duct dilatation. Again, by changing the window settings of the CT, you can see how beautifully the lesion is appreciated. So these were all T3, T4 lesions. So what are our challenges? When we get such cases, the patient is either not a candidate for surgery, one, or the patient ends up with a Whipple's with curative treatment. The challenge for us is that when the patient is symptomatic and presents to us, is to diagnose a T1 and a T2 lesion. I won't go in the details because of shortage of time, but the T1 lesion is just confined to the ampulla, that is the confluence of the ducts. T2 lesion is the lesion when it has involved the duodenal wall, and T3 is when it has involved the pancreas, and T4 is when it has extended outside the pancreas and the duodenum. So even if a small part of the pancreatic or duodenal groove is involved, then the surgery is out of your hands. So small lesion not obstructing the MPD and CBD is the biggest challenge, because we as radiologists know double duct sign, periampullary lesion hai bhai. But if there is no double duct sign, we simply ignore the simple enhancement or the simple nodule. We see, okay, it's not obstructing, it's not significant. So if the lesion or a nodule or any finding you see near the ampulla does not give an obstructing appearance, it should still be worked up with the clinical markers. Okay, the next point is single phase scan is inadequate. As I just mentioned, most of the lesions are hypovascular, or they are slowly, or they are more towards the slowly progressive end. So a delayed phase is essential. And non-contrast MRI has a beautiful resolution as compared to CT scan. So a comparison of a non-contrast MRI with a dynamic MR or a CT gives an excellent diagnosis for early lesions. I showed you a 2 millimeter nodule at the ampulla. MRCP has a crucial role. The non-visualization of the ampulla on any plane or any irregularity of the ampulla, its wall, might be the early sign of a T1 disease. And again, absence of double duct sign does not rule out a periampullary CA. Just what I just explained, this is a T1 lesion and this is a T3 lesion. T1 lesion confined within the ampulla, it is not causing any upstream ductal dilatation. This is a T3 lesion. It has infiltrated the duodenal mucosa as well as the pancreas. You see, you can appreciate the upstream duct dilatation. So the biggest, the aim of our daily work should be to avoid patient going to this stage. So early diagnosis. Okay, these two cases, this is a T1 lesion. The CBD was of normal dia, but it was prominent. It was 8 millimeters. MPD was 2 millimeter. And this is a T4 lesion. So you can compare small lesion. It was not a stone. It was a small lesion. Okay, this was a periampullary mass, non-visualization of ampulla, but the MPD was not dilated. The biliary ducts were dilated because predominantly the CBD was involved. This was a case of extrahepatic cholangiocarcinoma. Okay, this is very frequently seen, distal CBD stricture and with a floating calculus. So stone dekh liya CBD mein, report kar di, CBD stone causing biliary obstruction. ERCP suggested. ERCP हो गई, periampullary mass निकल आया. क्यों? पहले स्टेजिंग होनी चाहिए थी, कोई डायनामिक स्कैन होना चाहिए था, CT, MRI. So the non-visualization of ampulla should have been mentioned. The CBD stricture should have been mentioned, and the ampullary stricture is the cause of the biliary dilatation rather than the stone. Stone is just the floating thing. Small stricture, tight stricture at the distal CBD. This was the case of distal CBD malignancy, cholangio. Again, infiltrative mass. This was a CA of the head of pancreas. You can see how it has invaded the CBD, but it has spared the MPD. So some tips. So visualization of all periampullary ducts and ampulla should be there. The caliber should be seen, whether it's dilated or not, whether you see an interrupted segment or some absent segment. So you can call that a stricture. Wall of the ducts, whether it's smooth or irregular or a beaded appearance, some intraluminal focus or a filling defect. And again, the dynamic CT and MR plays a role. Mostly hypovascular lesions, which are T2 iso to slightly hyperintense, and delayed phase has a crucial role. Just to show you, this is a normal MRCP. You see the ducts are not dilated, but there's no non-visualization of ampulla. So what we did, we assessed the raw data, the source images. Again, there was non-visualization of the ampulla. In our department, what we do is we acquire the source images in two planes, the 3D coronals and the 3D axials. So when we looked at the 3D axial images, the source images showed the beautiful confluence and its opening. So ampulla was there. So you have to make sure every part of the drainage duct is seen. I'm ending it just to show you how a periampullary classical picture looks like. So to conclude, imaging has a crucial role in diagnosing ampullary and periampullary lesions. The use of all phases, especially the windowing and the post-processing techniques and reconstruction, helps avoid misinterpreting pitfalls. Not all early stage periampullary lesions cause double duct sign. These were my resources. That's what we can do now. I thank you all for your kind attention.
So, thank you, Mr. Tamara, for such a nice talk for CBT, something we come across every other day, a patient coming with jointers and something we need to sort out. And now the next talk is of Dr. Maria Zulfikar, and she's a consultant radiologist and assistant professor at Mayo Clinic in Scottsdale, USA. And she is going to talk on mimics of neoplasm on imaging. So we'll run her talk, and then she will join later for question answer.
Assalamu alaikum, everyone. And this is Dr. Maria Zulfikar. I'm a graduate of King Edward Medical University, and currently I'm working as an abdominal radiologist in Mayo Clinic. And this will be very interesting for the radiologists and also for the oncologists. I do not have any financial disclosures. So, oncology, when we're looking for oncological findings in the abdomen and pelvis, we want to make sure that we don't fall into pitfalls or don't fall certain benign findings as malignancies. So basically, what's the difference between a pitfall and a mimic regarding the findings in oncology? A pitfall is basically when a malignancy is missed, either the malignancy or the finding on imaging looks like benign, or it's not picked up at all. And then a mimic, on the other hand, is when a malignancy is overcalled and a benign diagnosis is called as malignant. I'm showing a case of a 35-year-old patient with rectal bleeding, and this is having arrived form. And you can see that the rectal sigmoid region is markedly thickened, and there's T2 hyperintency in the wall. there's a little bit of diffusion restriction in the different areas, but predominantly through on the diffusion sequences. And there's an area that looks a little different than the background abnormality, but the background abnormality is so pronounced that the reading radiologists correlated with the and you can see that area that sees fibrin multiple calcified structures which are consistent with tubules. So this is an example of used rectal meningioma. So the background abnormalities, the background rectum is like so abnormal that the reading radiologist superimpose finding of the hypointense mass with diffusion restriction. And this actually came back as, and this mass was also enhancing on post-contrast images. And colonoscopy was performed and on background rectum meningioma was this ulcerating mass. It was a tubulous adenoma with high-grade disease. So whenever we're looking at findings, the radiologist can fall into different types of errors that that have been like described in and about was most commonly the errors that the finding is just missed and the radiologist doesn't really have that finding. What I showed in this case, but that was an example of the satisfaction error, which is the second most common error, where you find a more pronounced, less important finding and miss the less conspicuous, more important finding. And this is actually another patient where you can see that this is a female patient and you can see that there's a large detectable mass on the right and it is filled up with like a solid mass of like. And this is what it was, a classic sign in radiology, what is called the CNMA sign, where these papillary projections kind of look like very interior surface, papillary borderline tumors, and 30% of these tumors are right. The radiologist picked up the right side of the tumor, but they missed the several findings in the left ovary. And this patient had recurrence of the disease in the left ovary, and then the surgeons had to go back and take out the tumor in the left ovary. Another case is the patient presenting with elevated PSA levels, and you can see that on the axial T2 negative there's a T2 hypointense observation in the right peripheral zone of the prostate gland, which has marked diffusion restriction. Is consistent with the pilots 4 or 5 weeks of this lesion. But if you're concentrating just on this finding, as the radiologist reading the study was, then they missed this halfway urinary blood because these prostate gland MRIs are obtained in like small field of views. So this was on like the topmost image on the MRI. It is important to know that in about 70% of the prostate cancer patients, and during their lifetime, they can have bladder cancer, and about 2.4% bladder cancer tumors can have prostate cancer. So it's important to kind of look at the bladder, urinary bladder, and you're looking at the prostate gland, and then look at the prostate gland, and you're looking at a bladder tumor. This is another patient, a 30-year-old woman presenting with recent miscarriage, and she's presenting with abdominal pain and vaginal bleeding. A CT was performed, and you can see that the uterus is enlarged, and it's large heterogeneous mass, and it has areas of hyperintension, it has areas of necrosis and hemorrhage. There's also extrauterine hemorrhage in the right lower quadrant, which has higher than simple fluid attenuation. So obviously, a beta ACT was performed to evaluate for any possible pregnancy or any tumor that might be producing the ACT, but a point of care ACT was made. So this is an important pitfall in gynecological imaging, because on imaging it looks like there's a large mass. But the most common cancer, which is hypervascular, in coin carcinoma in the pelvis. But coin carcinoma, the EC levels are extremely elevated. But the point of care, it is important to note that the point of care ultrasound, the point of care beta HCT is actually qualitative, and it's not quantitative. And this has a pitfall, and which we will discuss. When quantitative HCT patients were performed, they were like extremely elevated. So whenever this is what we call as a personal effect or the focal effect. It is defined as a false negative result in immunological reactions due to extreme excess of either the in this case the beta HCT levels. So the quantitative was extremely elevated against proven as where a person in mind this patient had proper management after that. Another young patient liver and urinary protein. This patient also has history of previous prostatitis, and he was actually given this history. When you look at the CT, you can see that there's this like multilobulated room enhancing collection in the region of the prostate, also trying to form like some sinus tracts or fistulous tracts into the surrounding soft tissues. And this was treated with a drain placement. 3 months later, this patient presents. This is the original CT, and these are the subsequent 3-month CTs. And you can see that despite the presence of a drain, these collections have increased in size. And now there's like frank fistulization with the urinary bladder. So this looks like a more malignant process rather than a simple infection. And given the low attenuation on CT, this is most likely a malignant mucinous process. So and this patient presented with little to no drain output and worsening collections in the pelvis. And there's like new extension into the urinary bladder. You can also see a communication with the rectum. So, and also you can see that the surrounding wall is like more thickened and more enhancing compared to the original CT. So this patient went on to get an MRI. And you can see that there's like this T2 hyperintense areas that correspond to the hypoattenuating areas on CT. There's this mass in the rectum where there's, which has transmural extension into the surrounding mesorectal space. And these collections have like thick peripheral walls, and these have like thick nodular areas of enhancement. The MRI also revealed a mucinous metastatic lymphadenopathy along the inferior mesenteric chain. So perforated mucinous tumor can also masquerade as an abscess. These can also get super infected. So even clinical picture can be very confusing when the patient is presenting. But some things to keep in mind is when you have cauliflower or polypoid areas of marginal contrast enhancement, it has like a progressive mesh-like enhancement pattern like in this patient. And these enhancement patterns are usually better seen with MRI than CT. And when there's like fistulization to the surrounding organs, you see mucinous metastatic lymphadenopathy, and eventually tissue sampling is needed in these patients to differentiate from infection. But if the fluid collections or cystic areas are increasing despite the presence of a drain with little to no drain output, then suspect superimposed mucinous process, which can involve areas of chronic inflammation, such as with Crohn's fistulas or a chronic abscess cavity, or in this case, a rectal mucinous malignancy just ruptured into the pelvis and formed these collections. So these were the potential pitfalls that I discussed. Now we're going to discuss mimics of malignancy in the pelvis. And so we're going to talk about the female pelvis first and then the male pelvis after that. So I've taken liberty to divide these mimics into different, like 3 different categories. So first, we're going to talk about tumor or tumor-like conditions. So neurofibromatosis type 1 is a condition where the patient has genetic mutations where it predisposes them to form different tumors, such as multifocal neurofibromas, which can be single solitary neurofibromas, or they can be plexiform neurofibromas. It's important to know that these plexiform neurofibromas can mimic tumors or metastatic disease. As in this patient,
you can see that this patient had a prior history of testicular cancer. This is a scrotal ultrasound where there's a testicular seminoma. It has internal vascularity, and this was resected. And the bottom row shows a CT performed 1 year later for metastatic disease surveillance. And you can see that there are these like low attenuating masses in the retroperitoneum, in the abdomen, and also in the presacral region. And so are these, at the time, the diagnosis of neurofibromatosis type 1 was not known. So you can see that, first of all, these areas are not very enhancing. They're hypo-enhancing lesions. And then additional findings that you can see that there are these cutaneous areas of nodularity in this patient as well. And then there is bony remodeling in the sacrum. All these findings are consistent with multiple neurofibromas compared to metastatic disease, which is much more invasive, much more enhancing, and then it would destroy bone rather than remodel it. So these are consistent with plexiform neurofibromas along the neurovascular bundle rather than metastatic lymphadenopathy, which is easy to assume in this patient with seminoma, testicular neoplasms, which really likes the retroperitoneum for lymphatic lymphadenopathy. So some clues that I already discussed would be useful to differentiate these lesions from malignancy. This is another patient with neurofibromatosis. She's a young woman presenting with recurrent UTIs, and a CT was performed. You can see that the urinary bladder is markedly thick-walled. There's mucosal hyperenhancement, and then there's like mass-like thickening of the cervix and the uterus, and there's also extension of this mass-like process into the perineum and also into the mons pubis. A MRI was actually, a PET MRI was performed, and it confirms that this area is like very mass-like, enhancing, almost looks like a malignancy. But on the PET portion of the PET MRI, there's very low level of uptake. And then if you scrutinize the spine of this patient, there is a posterior scalloping of the vertebral bodies, which can occur in patients with neurofibromatosis type 1, which happens actually because of spinal durolectasia. And these plexiform neurofibromas are usually, they remain stable over multiple years. And if for some reason a plexiform neurofibroma starts growing, then there's a risk for malignant degeneration. But this patient was followed over multiple years, and this plexiform neurofibroma was stable over many years. Endometriosis is one entity in the female pelvis which can mimic a lot of malignant pathology, especially with deep infiltrative endometriosis, where there is subperitoneal invasion by the endometrial lesion, and it can become very fibrotic and can look like cancer. So we're going to discuss a few cases of endometriosis which can mimic cancer. Usually what the usual lesion in endometriosis are endometriomas in the ovaries. So we see these like large cystic areas, which can be mistaken as cystic ovarian neoplasm. But on the T1 weighted MRI, these are T1 hyperintense, and these have T2 shading sign where the signal decreases on the T2 weighted imaging. On ultrasound, we have low-level internal echoes within these lesions. So easy to kind of differentiate from a cystic ovarian neoplasm, which otherwise has like solid enhancing areas. These endometriomas also do not have any internal enhancing components. Certain morphological forms of endometriosis can, however, mimic more solid neoplastic processes, such as scar endometriosis, where the patient has a history of prior C-section, and you can see a nodule along the left anterior abdominal wall. There's this, on ultrasound, it even looks more scary, where there is this solid hypoechoic mass with posterior shadowing. And on the post-contrast images, you can see that this is enhancing. But given the prior history of C-section and along this lesion along the C-section scar, this is very typical for scar endometriosis. This is another case where I'm showing that the patient not only has deep infiltrative endometriosis, where there is deep involvement of the rectum, But there's also a secondary lesion in the sigmoid, which starts from the serosa and puckers the morphology of the sigmoid, giving it a fortune cookie appearance. And this was resected and proven to be endometriosis involvement rather than metastatic lesion. And then polypoid endometriosis is perhaps the most confusing of the morphological forms of endometriosis, where you can see this T2 hyperintense heterogeneous lesion, and it enhances very mass-like. Some features that can be helpful in differentiating these conditions would be in the scar endometriosis, knowing the history of a prior C-section and the location of the lesion in a young reproductive age woman along the anti-abdominal wall C-section scar. This scar endometriosis was treated with percutaneous ablation. And for polypoid endometriosis, looking at the diffusion might be helpful where there is T2 shine through rather than high degree of diffusion restriction. And you can kind of see these like polypoid areas on top of that mass, mass that is polypoid endometriosis. Moving on to infectious conditions, which can happen in both men and women. I'm showing a case of pelvic inflammatory disease when it's like really extensive and a large hydrosalpinx can kind of fold upon itself, and cross-sectional images can look like multiple, kind of like a multiloculated cystic mass. But certain things on clues on imaging that you can look for are that when you follow these cystic areas, they appear to form a tube, especially when you look at them on the coronal or the sagittal images. That's what we call as a cogwheel appearance on axial imaging. And you will see signs of inflammation in the pelvis, including pelvic inflammatory fat stranding. So that might be helpful in kind of indicating that this could be an infectious inflammatory process rather than a mucinous or a necrotic malignant process. So, but in certain cases, it's difficult to differentiate. Like in this case with actinomycosis, you see this like just fibrotic enhancing tissue just filling up the pelvis, and there are like these sinus tracts. It's extending across the wall, abdominal rectus muscles into the subcutaneous wall, and just forming all of this entire mass-like process. So the key clue in this case is the presence of a long-standing IUD in the uterus. Usually it's like more than 3 years for a copper T, and then if for the Mirena, if it's like more than 10 years, then start thinking about an atypical infectious process. And this does not respect boundaries. This is a gram-positive, non-acid-fast anaerobic bacterial infection, and it results in like abscesses, sinuses, and fibrosis that mimics a malignancy. But presence of a long-standing IUD can help clinch this diagnosis. Ovarian hyperstimulation occurs in the setting of infertility treatment, and this is happening more and more because of increasing incidence of assisted reproduction in all over the world. And so because of strong hormonal follicular stimulation, multiple large thecal lutein cysts are formed, and that causes marked ovarian enlargement. And that can easily be mistaken as a cystic mass in women. And because of a fluid shift, because of vascular permeability, there can be concomitant ascites, pleural effusions, and then the patient presents with abdominal distension and pain. Usually the appearance is very ant mini, and you can just diagnose this on imaging. But when there's this is complicated by internal hemorrhage, then it will be difficult to differentiate from malignancy. And in those situations, follow-up exam, knowing the history of the patient is really important in diagnosing these cases of ovarian hyperstimulation. But when you suspect that this is ovarian hyperstimulation and not malignancy, rather than put the patient through like invasive procedures such as biopsies, imaging follow-up can be done to assess resolution of this process. So basically, history is key in these scenarios. This is a male patient who's being screened for prostate cancer for elevated PSA levels, and there's this discrete lesion which is very T2 dark, has marked diffusion restriction and low ADC value. And this was biopsied, and this was called as a pyroid spore lesion. And this was biopsied, and it came back as non-necrotizing and necrotizing granulomatous inflammation. And looking back retrospectively, this patient had history of urinary bladder cancer, which was managed with BCG therapy. So granulomatous prostatitis commonly occurs in first world countries, as like in the setting of BCG therapy, or in other countries where TB is endemic. So because of tuberculous prostatitis, it could be focal or diffuse. On MRI, two types of patterns are identified. One is a chronic pattern where there is not much diffusion restriction, but could be iso or hypoindents on high B value, and the size is usually less than 1.5 centimeter and mimics a Pyrex 3 lesion. And acute pattern, which mimics a Pyrex 4 or 5 lesion, is what we saw. And there's decreased ADC, and usually the lesion is more than 1.5 centimeter, and it's indistinguishable from cancer and usually needs a biopsy. And this is a case of tuberculous prostatitis I'm showing, which T2 hypointense, very marked T2 ADC, decreased ADC value, and then we have dynamic enhancement. Last category is iatrogenic, which can be also most confusing. This is a patient with history of urinary bladder cancer. He was treated with radiation therapy and chemotherapy, and this is his treatment, post-treatment CT for any recurrence. And you can see that the urinary bladder is markedly thickened, and then there are these. This is a contrast enhanced CT, and there are these intrinsic. These are these hyper dense foci along the wall of the bladder, maybe some foci along the mucosa, and also along external to the bladder. So this was called as concerning for disease recurrence. And then the urologist called the radiologist, and as I injected this new fiducial marker gel into the bladder prior to when I did the radiation. Could this be the appearance of the radiotracer gel? And a CT non-contrast was performed, and truly these lesions were hyperdense on the non-contrast CT, and these were not enhancing. And that's how injectable fiducial markers for image-guided radiotherapy look like on imaging, and they're used for precision targeting, and they're being used more and more. And basically they're composed of iodinated polyethylene glycol, which is hyperdense on CT and can be mistaken as a recurrence in the setting of recent radiation therapy. And usually they're absorbable and with a mean visibility of about 3 months. This is another patient presenting with right hydronephrosis, and this patient had a bulking agent injection performed a few years ago, and the history was not very clear in the patient's chart, but that's how these bulking agent injections look like: well circumscribed kind of cystic masses at the uretrovesical junction. And idea is to prevent reflux, so they may be associated with mild hydronephrosis, as in this case, and that's expected after a bulking agent injection. So not to confuse it with a urothelial lesion and call it concerning for cancer. Another entity that commonly comes up is mesh plug post-hernia repair. These mesh plugs are designed to incite a granulomatous reaction, and then they induce fibrosis, so to prevent the recurrence of the inguinal hernia. And these can be T2 hypointense, and they can enhance because of the fibrosis. And when the acute granulomatous inflammation is happening, these can even be avid on PET, which can be very confusing because this can, especially if a patient is having PET for some other malignancy, these can be confused with lymphadenopathy, and many people have tried biopsying these mesh plugs as well when the prior history is not clear. So important point is to, when you see this finding, these usually appear oval to kind of round in appearance, conical in shape, and sometimes overlying surgical scarring may be helpful in assessing this is like a prior surgery rather than a lymph node. But knowing the patient's history is really important, not to overcall this as an enlarged lymph node. This is an extremely interesting case, and this patient actually presented to a nephrologist, and they had end-stage renal disease, and they also had markedly elevated serum calcium levels. And PET-CT was performed to exclude the hypercalcemia from a paraneoplastic process. So this PET-CT was done to look for malignancy, and you can see that in the gluteal subcutaneous tissues, there are multiple nodular mass-like areas which are infiltrating the soft tissues, and these are very avid on the PET-CT. These can very easily be mistaken as a cancer, especially in the setting when they're looking for paraneoplastic syndrome. Could this be like a sarcoma or something that's causing hypercalcemia? But this is a very classic appearance of subcutaneous free silicone injections, which are done for aesthetic purposes in many countries. These are illegal in the United States, but people still get them. They can be gotten in like areas where these are not like legally enforced. So people travel to these countries to get these aesthetic injections. What happens is that when free silicone is injected into the soft tissues in the human body, it incites a severe granulomatous response. And sometimes a granulomatous response can be so severe that it can cause hypercalcemia. So that kind of confuses the clinical picture, and the radiologist can help identify characteristic appearance on imaging and prevent invasive biopsy. Important thing to note is that the hypercalcemia that is associated with silicone granulomatosis is treated with steroids. So it's important to pick up these findings and tell the ordering physician that this is this diagnosis and not anything malignant. So some key take-home points with this lecture is that malignant tumors can be missed or mistaken as benign. Various non-neoplastic or benign entities can mimic the appearance of malignancy on imaging on the flip side. And then deep infiltrative endometriosis has many faces that can be mistaken for malignancy. It's a prudent radiologist will pick up those findings and not fall into those pitfalls or make those mistakes. And knowing the patient's demographics, clinical history, and lab correlation is crucial for the radiologist to make an informed and correct diagnosis. Thank you, everyone. I hope everybody learned something from this lecture. And if anybody has any questions or any feedback, please feel free to email me at this email address. Thank you so much.
Sharing such a wonderful talk. And now we'll have a interactive session for panel discussion. So can I request Dr. Zafar Sajjad, Dr. Amara, please come forward, Dr. Shehzad, and everyone, please, so that we can have more productive discussion, please. So the first case is by Dr. Atif Naveed. Click, please.
Thank you, Dr. Amir, for inviting me. I'm Dr. Atif Naveed from Shaukat Khanum Hospital, Lahore. Dr. Atif. Yeah. So I'll present the first case. Dr. Kashif is not allowed to comment because me and Dr. Kashif has reported this case. So this is the first case, 51 years old female with acute onset of bilateral paraplegia and inability to walk with urinary retention and bowel incontinence. Patient has a remote history of pituitary apoplexy and surgery in 1995, like almost 20 years ago. So these are the cases of patient had a spine MRI, thoracic and cervical. Light off kar dein kindly. So should I help you guys?
Mhm. T1 sagittal is not there, but it doesn't show any hypointensity. And we don't do diffusion in our institution. So basically, you want, anybody want to describe? Mike?
So again, looking at the spine, it's sometimes difficult to be sure whether, unless you're familiar with the machine, whether what you're looking at is truncation artifact or real. So there appears to be T2 hyperintensity through the upper dorsal spine, which appears to be central. You've given us a T2 axial, that's a T1 axial, right?
This is a T2 axial. Because CSS is bright. It's not very clear. I can tell you, it's not very clear, because that's why we recalled this patient to have a scan again for 3T, because this was 1.5 Tesla.
And there also, I mean, this also appears to be extending up to the orbis. So like to see some good T2 axials from that area as well.
Okay, so yeah, so I will also point out one more thing. Patient had a history of pituitary apoplexy surgery in 1995, but pituitary gland looks totally normal here. And I had a conversation with a neurologist who referred this patient to us, and he said patient was blind for more than 20 years. And I was not happy with axial images, because axial is not helping. So we recalled this patient to have a scan again in our institution on 3 Tesla MRI. And this patient came back after 12 days in our institution. And we did this spine MRI again. And patient had the steroids as well in between. So you can see now those lesions are very like gone, most of them, like especially the cervical spine.
Well, I think there's a big difference in the images that you showed before and these images. One is, of course, these appear to be more clear.
Yeah.
What we saw on the previous images are not very evident
Mhm.
on the current images. But what I can appreciate is the subsequent image, if you could please, yeah. So the dorsal cord, I find it sort of tapering down, reduced in caliber as we follow it down.
Yes.
Inferiorly.
Yes,
So
I agree.
is there some level of some kind of atrophy?
Yes.
The cord atrophy.
Yes, there is atrophy.
Yes, this is what I thought.
Yeah. And also we, at the same time, we try to do brain imaging and orbit imaging to have complete neuroaxis imaging. So we did this MRI orbit. And you can see the optic nerves here. Any comment? Atrophy. So there is bilateral symmetrical atrophy of the optic nerves, almost all the intraorbital component. It was seen up to the chiasm, but it is not included in this image. And then we did the brain as well. Any comment on the brain findings? Speaker there. Speaker kindly. Either. Dr. Zafar Sajjad.
So on this one, there are multiple white matter. How old is the patient?
51.
Okay, so there are multiple white matter changes. On here, they look more periventricular.
Yeah.
I don't see any juxtacortical one, at least on the ones that you have shown. And obviously, we don't have any infratentorial or brainstem imaging on here. So
that was clear.
So just these images?
Yeah, we don't have any infratentorial or brainstem lesions on this MRI. They are not shown here.
Okay.
Do you have sagittal? Sagittal?
No.
No. Okay, just these.
Actually, we did sagittal, but there was no Dawson finger on sagittal. So these are not very typical for MS Dawson fingers or U fiber. Yeah. Yes, so we sent antibodies for aquaporin 4 receptor, then they came back positive.
So then in the first one, your OBEX signal was real.
Yeah, so
So the signal going up to there is real.
it is real.
Yeah.
Because
But a patient responding that rapidly to steroids with long segment myelitis would be very unusual, especially in neglected NMO spectrum. So if this is 12, so what either this was an artifact, but if the implication is that that was long segment myelitis, responded to pulse therapy and became completely normal over 12 days, would be very unusual, because most patients with NMO spectrum, the cord changes are actually persistent and do not go away even with treatment.
She proved clinically, yes. So she actually, I agree with you, but aquaporin 4 receptors are more in the periaqueductal gray matter in the spinal cord. So all we are seeing actually is a signal of abnormality. I don't think this is artifact. I think these are real, because aquaporin 4 receptors are in the periaquedutal.
No, I accept that. All I'm saying is that
it is unusual.
That's a very dramatic response, because if you look on the second one, it's good, except for the
almost
cord
gone.
atrophy, you don't see anything.
Yeah.
The other somewhat unusual is that you said that the atrophy extended up to the chiasma, but retrochiasmal areas were normal. Again, with such advanced atrophy, you would almost certainly see posterior visual pathway changes. So involvement of the chiasma or the optic tracts would not be uncommon.
Yeah, the optic nerve atrophy was very clear. Optic chiasm was also atrophic, but optic tracts I was not very sure whether to call it atrophic or not. But these are long segment lesions in the optic nerves. I agree with you.
Yeah. So one thing I've learned from experience is that anytime you see chiasmal involvement, you're with a neuritis, you're almost always dealing with an NMOS. So for MS and for everything else, even the metabolic ones, the involvement is almost always, even if it's long segment, it's almost always anterior to the chiasma. If you see chiasmal or retrochiasmal involved, you're dealing with NMOS.
That's a very good point. That's a very good point. Thank you. So okay. So we can start the question answer session for the panel.
Do we have any more questions from the floor? You have a question.
How is ADC on pseudoprogression?
So again, the problem with pseudoprogression is that there is no universally accepted definition of pseudoprogression. So if you look at, one of the biggest problems with dealing with pseudoprogression or looking at meta-analysis is that everybody uses a slightly different term or slightly different definition of pseudoprogression. So it depends on what is causing that pseudoprogression. So if the pseudoprogression is because of an inflammatory component, like we saw, like the case I showed, in which case the ADC would not change, or should only show T2 shine through, should not really be restriction per se. But if the pseudoprogression, so remember, pseudoprogression means that what you're looking at is not tumor growth. Something else is causing either the lesion to enlarge or the enhancement pattern to change. So if that's the case, then if it is not inflammatory, there is an element of ischemia involved with it, then you may have diffusion restriction. But by and large, the diffusion restriction should not occur in patients who have pseudoprogression, as opposed to high-grade tumor growth. So if you have, and again, doesn't always work, but if you have diffusion restriction in a lesion that is showing growth, you almost always have tumor recurrence. So if I see diffusion restriction, to me, that's tumor recurrence until proven otherwise. It's not really necrosis, it's not pseudoprogression.
I have a question, Dr. Zafar Sajad. So we do DSC perfusion in our institution, and with DSC perfusion, I have come across one major pitfall is that when there is hemosiderin deposition in the tumor area from radiation therapy or chemotherapy, then that can artificially make CBV high. So in that case, do you have any experience with DCE or ASL perfusion? Do you think we should?
So we've had a scanner capable of ASL perfusion for the past year or so. We've been trying ASL perfusion. The problem with ASL is it only gives you a CBF. It does not give you a CBV. It gives you a single parameter to look at. Doesn't give you transit time, doesn't give you anything else. So ASL is very useful for everything other than pseudoprogression or radionecrosis.
Okay.
So it's very useful for strokes. It's very useful for reactive hyperemia. It's very useful for AVMs. We have seen things that we couldn't really figure out what was happening, but we could see early venous filling on the ASL, and that made us go back and look at what else was happening. So ASL is very useful, but not for pseudoprogression.
Okay.
Thank you. I think the floor is open for a question and answer session. Yeah. So the I think,
I thought we can give more time to the question answer.
okay, fine. You got other cases?
No, I think looking at all the other people, so many questions, I think we can.
Okay.
Okay.
So we'll just, so first of all, I would like to thank the Shaukat Khanum team for conducting this symposium here in Peshawar against the backdrop of the beautiful historic heritage building of Islamia College, which I can see, university, in fact. I being born and bred in Peshawar, I think it's an honor for us to have the symposium here. First of all, I think the consensus is that we'll have the question and answer sessions from the speakers who are here available on the floor. So Dr. Zafar Sajad, he spoke about imaging evaluation of brain tumors after treatment. So the house is open for any questions, please. Anyone?
Online participants, floor is open for you as well. Just raise your hand and I'll let you talk.
Okay.
I think there's a comment on about. So there's a query that what's the difference between. So the point I was making was that if you have chiasmal involvement in somebody who has optic neuritis, chiasmal or retrochiasmal involvement, what you're dealing with is NMO spectrum disorder rather than and NMO and related. So anti-MOG can be chiasmal or retrochiasmal and NMO spectrum disorders. So what you're not dealing with is classic multiple sclerosis. Classic multiple sclerosis tends to have short segment optic nerve involvement, and even if it does occasionally present with long segment involvement, it is almost always anterior to the chiasma, does not involve the chiasma or the retrochiasmal areas. So that was the point. Okay.
Any other? So, Dr. Zafar, it's indeed an honor to have you amongst us here in Peshawar. My query or comment would be that I think your topic was extremely interesting always. I recently listened to one of your talks in Karachi. I was there on the TNM staging of lung cancer. So regarding the glioblastomas, you explained 3-4 phenomena like the pseudo progression and the radionecrosis and other phenomena. So my query is that how does radionecrosis impact the patient clinically?
So the issue really with radionecrosis is that it is destroying brain.
Yeah.
And you will have deficits secondary to the radionecrosis per se. The reason it is important, and there is really no treatment for it. The only treatment with proven benefit is hyperbaric oxygen, and at least to my knowledge, hyperbaric oxygen is not available in Pakistan, at least to the civilian population. There may be a naval station with hyperbaric oxygen facility, but I'm not sure. So even in the West, hyperbaric oxygen therapy is very, very limited. So that's about the only thing that shows benefit. The issue is not to treat them with more radiation.
Okay.
And that's why it is so important to recognize that what you're dealing with is radionecrosis, so that you don't send the patient back to the radiotherapist for more radiation. Even because sometimes radiation, they still have capacity to give more in the sense that they have not reached the limit of the whole brain irradiation, whole brain dosing. So there may be capacity, and there is an increasing trend to refer these patients for, even if when they are close to the limit of the whole brain irradiation, to send these patients to stereotype radiosurgery, whether by CyberKnife or by Gamma Knife, with the thought that you can boost the local area without having the detrimental effects. Absolute disaster. If you give radiation therapy to patients who have radionecrosis, you are going to end up with virtually the whole hemisphere at times I've seen just completely wither away. So that's the important.
That's the importance of the radionecrosis.
Of recognizing that what you're dealing with
this is radionecrosis.
and not tumor growth.
Not tumor growth, and that is how it impacts your further treatment plan.
Absolutely.
Yes. So, because glioblastoma is virtually a death sentence for most patients, and so it was very interesting to see the different aspects which need to be looked at in the follow-up of such patients who are on treatment. So anyone else, if there's any other query, then we move on. Yes, please.
Thank you very much. Sorry, I missed your wonderful talk. I was at another session. My name is Irfan, consultant neurosurgeon at Shaukat Khanum. And I totally agree with your comment, radiation necrosis versus progression. It's a topic that we discuss again and again at our MDT meetings. And I know one case, which is actually a breast metastasis treated with SRS and presented a year later with an expanding lesion, which was enhancing on MR, continued to increase at 3 months' time following as a follow-up scan. And at MDT, we failed to come to a conclusion. Is it progression again a year later down SRS, or is it actually radiation necrosis? So we didn't decide to go for any further radiation or chemo, and went actually for surgery. This was a left temporal lobe lesion, and had a good discussion with the patient. We are going into your left temporal lobe with a view to take away this lesion again, and there could be potential complications like having speech deficits or memory issues. And she said, "Go ahead." She's a young lady. She's a teacher, and it was very close to her heart that her speech remains intact. So she eventually pulled through the surgery, and the pathology came back as necrosis, no tumor. So One issue is if we can't decide on oncology in terms of our clinical scenario, all the armamentarium we have in our imaging, if we can't decide is this tumor, is this necrosis, I think one of the way forward is to get another biopsy and see what it is, and probably looking back in retrospect, it's a good learning curve. Where do we fall short in terms of making a radiological diagnosis?
जी आप इधर आइए
So I actually showed a case today, again, a metastatic adenocarcinoma unknown primary with exactly the same thing that happened. Patient presented 18 months post-radiation with an enlarging lesion, and that lesion continued to enlarge for at least another year post the initial presentation. We did perfusion. Perfusion said hypoperfused. We did a PET, and the PET said no metabolic activity. And I think FDG PET in that scenario, FDG PET does not work for all of the brain tumors. You need choline if you have available, which I don't think anybody, at least to my knowledge in Pakistan, is offering yet. But a negative FDG PET at least tells you that this is not a high-grade lesion.
Okay.
So we sat on it. We did not this. So this lesion was growing, was more and more and more, and brain was being involved. But we kind of kept hands off, and I showed the 5-year follow-up on that patient, and the 5-year follow-up, the thing is shrunk down. There is still scarring, there is still some nodular enhancement, but it's not tumor. And the time has shown clearly that it's not tumor, that the initial radiology was correct. However, sometimes you don't have that luxury. In a young patient with a temporal lobe lesion, which is growing, where you may be becoming, or the patient may be becoming progressively aphasic, I think there is a role to go and get more tissue for histopathology. The question would be, what is the risk involved in getting that tissue?
I agree totally. And I'll come to another case now at hand in my clinic. She's a young lady again with a very rare neuroendocrine cellular breast metastases of a neuroendocrine origin. And she had a lesion in the cerebellum, and we had a good MDT discussion, quite deep along the tentorium on the left side. And again, with discussion with the family and the patient, we decided to go for SRS. And she got 25 gray in 3 fractions, and she did well for 8 months. And now she's back with a similar situation. Regression initially at 6 months and 8 months, a bit of progression, enhancement, and edema. So she came to me and I said, we just wait for another 3 months. As you mentioned, these lesions continue to expand. So radiation necrosis behaves almost as aggressively as a tumor in its biological progression and its radiological progression, and then a final, so to say, an atretic phase where a scar is left. Again, a very calculated decision what to do, but the patients are, kept in the dilemma: is this tumor? Is it necrosis?
So again, the posterior fossa is a completely different situation, right? So in the posterior fossa, there may be a case, even when you know that this is radiation necrosis, to go in and decompress, because what you don't want is that, because this in the acute phase will have mass effect. And so therefore, even if you know that this is radionecrosis and that it will eventually settle down, there may still be a place for surgical decompression there, in my opinion. I'm not a surgeon, but
I agree. But it's a very delicate balance that we need to achieve.
Absolutely. I mean, so there is really no right answers here. Because again, if we had choline PET, we could look at least the glioblastomas or the or the astrocytomas one. In my very limited experience with neuroendocrine tumors in the brain, they can look completely crazy. They can look like, oh my God, crazy. And especially if they are being treated with the newer agents, all the monoclonal emeximab, whatever, which I keep forgetting the names of, which I always have to go look up. What does this one do? If somebody asks me, this is what the patient is on. And they can give you changes in parts of the brain that weren't primarily affected by the tumor. And then you're wondering, is this metastatic disease? The post, I mean, I had 20 minutes, so I didn't even go there. But the scenario or the landscape with post-op brain imaging is becoming increasingly complicated and increasingly challenging and increasingly fraught with misdiagnoses, over-treatment, etc.
Sure. Thank you very much.
Thank you, Dr. Zafar. Thank you so much. So we go to the next speaker who's here with us, Dr. Amara, who spoke about periampullary malignancy imaging findings and challenges in early diagnosis. So any questions, please?
Dear audience, if there is any question, I'm talking to the participants that are online. Can you please raise your hand or type in your question? Uh, 81. 81.
81.
It was above 90 just a few minutes ago. Okay.
Okay.
Someone likes you.
So Amara, thank you so much for a lovely presentation. What I gathered from it was that something very basic, that is one of the slides that you showed of the stone and the stricture at the end is the cause and effect phenomena, which is one of the basic rules of radiology and interpretation of imaging. Besides was the multi-modality approach, but I always stressed on judicious multimodality approach. That you compared the different, without contrast, the dynamic imaging. And so it was wonderful and it was very informative. Thank you so much. We move on to the next speakers, who, if they are available, I think most of them online, the virtual ones. Yeah, so Dr. Maria Zulfikar, consultant radiologist at Mayo Clinic. Yeah,
Anyone
okay.
from the floor?
So mimics of neoplasm on imaging.
Anyone from the online community? Please raise your hand. Okay.
So
Okay, no questions.
no, okay.
Here's clear.
So Dr. Maria, thank you for a lovely presentation. It was a beautiful case mix that you presented. Lots of learning points which were presented to the audience. She spoke about pitfalls. She spoke about mimics. She spoke about benign and malignant mimics, coexistence, about superadded infections. And the complex ways in which different things present and the interpretation. And what I liked, the comment that you made was about the informed diagnosis, the importance of history, the labs, and that's how the radiologist is able to make an informed diagnosis, which will be beneficial to the patient as well as to the treating physician or the surgeon, and provide a roadmap. So thank you so much, Maria. It was wonderful.
Yeah, thank you. Thank you so much for having me.
It was wonderful. Thank you. Next, we move on to the other virtual speaker, learning from discrepancy. Ramchandra. Yes.
Hello.
So, yeah. Hello there.
Any questions for Dr. Chital? from the floor? Online?
Please.
Hi, Ram. Thank you very much. I really appreciate, for your time and then, like staying here for the question and answer session. Just wondering, I don't know, how we deal with it. And there's always balance, like when we were training between the learning or the training opportunity versus the service commitment. Almost the same dilemma we are coming across when we do these meetings, like, learning from discrepancy, which we are running regularly, which is good as a part of clinical governance. But the QA department of the hospital, now they also want hands-on that data, that, discrepancy data and all those. So far we are asking them, okay, yes, but it is a learning opportunity. We do not want to mix it with your quality data. Otherwise, people will not put the cases. Did you come across any situation like this, and what you will suggest?
I think it is a very, very important issue you raised in terms of, and it's there. This is a problem everywhere, not just in your hospital. It's about culture. Here, I can quote one example. One of the medical director asked for the data of the discrepancy meetings. You wanted for the particular radiologist missing a lot of. We want to know exactly from this meeting how. And the discrepancy lead said, "No, I'm not going to reveal any data." That's one issue. The question you have raised about the timing and the sorry if I understood correctly, is not to share the individual person's data. That's the key. You have to keep it anonymous. If you want people to engage, you have to keep it anonymous. No matter what mistake, what it is, it has to be anonymous. That way people will engage. Otherwise, people will start hiding stuff. Because if management knows or somebody else knows, people will start feeling, oh, I will lose my job or reputation. If you keep that, then people will start hiding things and then nobody will learn. It's more damaging than trying to share such data with anybody.
Yeah, thank you. Thank you very much. And one more question from Dr. Kashif.
Thank you, Dr. Chital. I have one question. So is it the responsibility of the real meeting or real team members to decide whether a specific harm has occurred to patient or not, on the basis of any discrepancy which has occurred while reporting?
A very good question. I think one way the UK has evolved over the period of time. I mean, I think if I go back 20 years from how this has evolved, this similar kind of dilemmas were there. Slowly, what has been worked out here, which is working well, is to separate the two processes. For example, if you are reporting a case and you see previous imaging and you feel that should have been picked up by a colleague or somebody, and then you think that has created harm, the responsibility is on you to do it I will explain how it is done in the UK, then we can try to work out. Is first submit the case to discussion for learning anonymously for everybody to learn, this happened, these are the lessons to be learned, we should be careful. So that's one issue. And the harm issue is a separate process. If you feel it is really has caused harm, then we have something called as duty of candor, where the primary person who submitted has to submit to the management saying some harm has done. Maybe we need to talk to the patient or relatives and explain something has happened. So that's kind of two separate things. So it will be difficult for the realm or the discrepancy lead or in the meeting to judge somebody, because you are already biased in the meeting. Everybody knows now all the cases discussed here, something has gone wrong. So any judgment passed by team members or lead is a bit difficult at the time. We are already going into the meeting knowing that all the mistakes are discussed. In the pile of middle of 10 scans, if you are reporting, in a real life scenario, it can happen. A lot of these mistakes, to be honest, nobody comes, none of us go to work to miss something or to do harm. It's a complexity of the workload, the number of scans, the imaging is increasing, fatigue. There are a lot of science and complexities involved why we mistake. It's not just simple miss. When we are looking at fresh with the benefit of hindsight, it looks very clear when we, for example, lung cancer, we often see lung cancer, and then when we look back at x-rays 5, 3, 4 years down the line, there is something. Now we are going back with that benefit of hindsight. I've seen a big lesion, my eyes will be drawn directly to that x-ray in that location, and I find something. Whether if you give the same film to 10 people and prospectively in the middle of a reporting session, on a busy session, whether everybody will pick up is a different thing. So that's how I would put it. So we have to be careful about judging somebody else. We have to put ourselves in their shoes and think what situations, what might have contributed to this. Difficult.
Thank you. Thank you so much. It was a wonderful presentation because it was, I think, different because the rest were all, mainly about images and stuff, how you interpret different things. But this was about what you showed us was about teamwork, about positive feedback, taking feedback in a positive way. And I think it would be a very healthy activity for different departments to adopt it because as they say, to err is human. So everybody does err, but it's best that when you learn from your mistakes and you help in the management of the patient as well. Thank you so much.
Thank you. Thank you for the invitation. Thank you.
And of course, the Dr. Damien, any question from the very first presentation? I like to offer my apology again in terms of, the audio quality or, no audio, like for the first or even the second session. I have already emailed to the symposium management in terms of so that when we will upload the recording of this session, we will upload the recorded segment again, the pre-recorded, so that the audio quality for the online availability, it should be adequate. So questions for Dr. Tolan?
Any question for Dr. Tolan online? Can you get regarding? Anyone from the floor?
Yeah. Dr. Tolan, so my question, thanks for sending the presentation. And as said earlier, I think yes, I was one of those people. I did comment sometimes the peritoneal reflection saying, yes, it is like T3 and didn't call it T4A, thinking, yes, it should be more nodular to call it T4A. But yes, that's learning for me. The other thing is the low rectum or the anorectal region. What I used to do was that if the tumor was involving the external sphincter, like, the intersphincteric plane is gone and the fat plane is lost, then yes, would call it T4A. But I was calling T4B only if it had involved the outer margin of the external sphincter. Then so it looks like that I needed correcting myself. Is it true? Is that learning point I learned, or would you like to say something about it, please?
So I think, I hope you can hear me okay in the room.
Yes, the recording in the room was okay. It was the online.
Technical aspects of the TNM staging are quite challenging. And I suppose if this is not something that you routinely use in clinical practice, this is going to be a very, very specific thing. So I expect our neuroradiology colleagues won't know what we're really talking about or why we're interested in this. But I think the key with all of these aspects of the specifics of TNM staging and rectal cancer is really to guide the treatment of the patient. So I think sometimes we beat ourselves up with not really having the specifics absolutely perfect. But I think particularly when we're talking about the sphincter involvement in rectal cancer, it's probably more important that your surgeons and oncologists understand what you're saying and that you're giving a good description than necessarily that you're putting the right T at the end of it. In our sort of MDT sort of review, which we published as that document that you saw in my talk, we recognize that actually a lot of radiologists do struggle with some of these technical aspects. And some of that is down to the way that TNM is actually described at the moment. It's actually quite a basic way of describing how you should look at tumours. And actually, again, as radiologists, we're all about the detail. We're sort of trying to describe these really, really fine points and try and get that message across. And the way that TNM works is it doesn't really allow us to get across that granularity in our reports. So hopefully that document has really sort of highlighted some of the areas of problems for radiologists with TNM, but also to sort of get radiologists to think about it in a little bit more detail. So to answer your specific point about what you should call external sphincter involvement with a rectal cancer, you call that T4B. Okay, so if any striated muscle or any fat beyond the mesorectal fascia is involved by tumour, that should be considered as T4B because it's involving an anatomic space beyond the mesorectum.
Yeah, thank you very much.
Any more questions?
Thank you. Thank you for a lovely presentation. My learning points were that regarding oncological staging, the emphasis should be on a more detailed, structured, objective format, as you mentioned, Performa. And the key again is the MDT. That is the platform in which the radiologist gets to know what the surgeon or the physician requires, and you're able to follow up the patients as well and add more clarity to your reports in the future. Thank you so much.
Thank you very much.
Thank you everyone for joining. It was so wonderful to have you, from everyone, and especially thanks to, Damien, to Ram, to Maria, to Dr. Zafar Sajjad, and, Dr. Tahira, Amara, everyone, for their precious time, from their daily activity and coming over. I really appreciate, for your company. Thank you. So nice of you. Cheers.
Thank you all.